We are at our beginning slide, and I'd like to introduce today Dr. David Acker, an independent medical consultant for OB Consult and SE Healthcare Quality Consulting. The title of his talk today is Pre-eclampsia Revisited: What is Old and What is New? Dr. Acker, who has had more than 35 years of experience, was the immediate past chief of OB at Brigham and Women's Hospital. And he's been involved in and has been passionate about OB patient safety throughout his career. He is a much sought-after reviewer of OB cases, and he brings his extensive practical clinical knowledge of this topic to the webinar today. So Dr. Acker, I'm going to turn it over to you.
Thank you, Peg. And good morning to all of those who have signed on. So, let's start. Well, let me tell you the goal, my goal, and then I'll tell you the goal of management of hypertension. My goal is to review with you during these 45 minutes two of the classic contributions to the obstetric literature in the field of hypertension in pregnancy as a foundation for the new work that has been distributed by the American College of Obstetrics and Gynecology. So, first, the goal of the management of hypertension, and I'm going to try not to read slides to all of you. I'm merely going to leave the slides on long enough for the average person to have read it, maybe even taken some notes, but to tell you the bullet, the message from the few bullets of the message on the slide. And it's very obvious that the people, the women, who suffer from the complications of either chronic hypertension associated with pregnancy or the acute hypertensive complications have as their goal, and therefore it's our goal, that they end the pregnancy as healthy as they can be without suffering certainly preventable complications, and for those complications that occur, they are competently handled. Similarly, as all of us would want with all of our children or grandchildren, the goal for the fetus is to become a neonate in as healthy a condition as is possible. I've put up with the what's old, and obviously I have no idea how old anyone in the audience is. I can't really see any of you, but I wanted to point out that in 1976, the people at Parkland Memorial Hospital in Dallas basically put out this classic paper. And for those of us who are in our residencies or early faculty appointments, having read this article, and if it is possible to go back in your library, in your hospitals, to look at this article, you will see the wisdom of a clinically oriented group of very practical clinicians, giving you the benefit of their experience. These people are still editing the classic Williams textbook of obstetrics. I noticed the new edition has come out. And they have continued to make contributions to the care of women. Here's what they showed. This is 1976. And we're talking the era before there was ultrasound. There were not very many antenatal testing that could be done. By taking people, and many of the people cared for at Parkland Memorial Hospital were medically indigent, taking, and young, taking the patients who were diagnosed with this problem and keeping them in the hospital until they delivered, and then comparing them to a smaller group of people who, for a variety of personal reasons, couldn't stay in the hospital, the perinatal mortality was dramatic. The difference between 9 per thousand and 154 per thousand was all the evidence they needed to promulgate lesson number 1 in 1976, keep them in the hospital. Now, things have changed as the intervening decades have gone by, and we'll get to that as we get to more modern papers. But the first lesson was keep them in the hospital. And the next slide shows what happens when they come in. I hope this is clear, and I'll point out the areas that I'd like you to look at. The blood pressure when the patient came into the hospital in the middle of March, in the 30th week of her pregnancy, was very, very high. And merely with a sedentary, and you'll see not necessarily strict bed rest therapy, the blood pressure settled down, and time went by, and as we've probably all seen in life, all good things come to an end, and here under observation, with frequent nursing and physician observation, the uptick in the blood pressure was noticed. The woman is delivered, and if you look at the delivery information at the bottom, a Apgar 99 baby is delivered from a woman who at week 30 in 1976 came in with significantly elevated blood pressure. Okay, let me summarize what we learned from these giants in obstetrics 38 years ago. Strict bed rest, not necessary. And sedating people so they could be at strict bed rest is obviously also not necessary. In those days, putting people on very low salt diets, prescribing diuretics, was very, very common. These people in Dallas put an end to that with this publication, that neither a low salt diet nor diuretics had any positive impact on the disease process. You had to know some of these people in Dallas. They were not overly impressed with new, unproven laboratory interventions and were more concerned about sequential, meticulous clinical observation. And they were unimpressed with serial amniocentesis. But what they never stopped stressing was close clinical bedside monitoring, which enabled the nurse, and I'll include the nurse here, and the doctor to safely observe the illness. 1976. What did the authors have to say? Well, they were very proud that none of the mothers died and that the perinatal mortality was as good as I mentioned it. And they cautioned over and over and over again, vigilance is necessary. And when we get to the modern era, the ACOG Recommendations, what is not new is the emphasis on the ever-changing nature of this illness, and hearkening back to 1976, if an illness can have subtle but dangerous changes, and we don't have any medication to cure the disease, then the only way to protect the patient is by constant vigilance. So when you'll see that in the current papers, or you see it in this classic paper, constant vigilance is the hallmark of quality care here. Okay. If you look to the bottom of this slide, hardly in font big enough for anybody to read, you will notice we have jumped to 2003. And I have put with some detail a summary of one of the other giants in American obstetrics and gynecology, Dr. Vaha Savai, who it seems has been writing all his life on the management of hypertensive complications of pregnancy. And now, approximately a quarter of a century after the classic Dallas paper, he wants to summarize what is now known about this illness. And you'll see some things are the same, some things have changed. First of all, he specifies the concept of gestational hypertension. The implication here is that there are no other signs of this illness called preeclampsia. And in 2003, what that implied was that there was no significant proteinuria. We'll see what has happened to proteinuria when we get to the more modern era, currently, more modern than 2003 at least. But for the time being, the illness that Dr. Savai is talking about is characterized by an elevation of blood pressure. By this time in 2003, the triad of hypertension, proteinuria, and edema had become a duo for preeclampsia of hypertension and proteinuria. The edema, lower extremity edema, had dropped out as a diagnostic criterion. Here, Dr. Savai is focusing on this illness of newly diagnosed hypertension in the absence, in those days, of a dipstick estimate of proteinuria, or, in the absence, you wouldn't be doing a 24-hour urine. And it was defined as a new onset hypertension of 140 millimeters of mercury over 90 millimeters of mercury. But now let's get to this problem that no matter what one reads, a interval of time, and 6 hours is common, is necessary for the next blood pressure to be taken. And that's great if the patient shows up at 8 o'clock in the morning or 9 o'clock to your office. But what happens if she shows up at 3 in the afternoon? I believe that neither she or you have any intention of having her stay in your office until 9 or 10 in the evening to check on the blood pressure. The issue here, and I think it's a very important issue, that on the one hand, one reading, maybe a second one separated by 5 or 10 minutes during a busy office session, does not meet the criterion. Okay? By the way, let me tell you something else that doesn't meet with the criterion. When you come into the patient's cubicle to evaluate them, and they're lying down and listening to their iPhone or something like that, and the blood pressure has been taken with the patient lying down, let's just say that doesn't count. The patient to have a blood pressure taken must be in the sitting position. Once you lie the patient down, you've already begun some form of treatment. Must be taken in the sitting position. Now, what is going to happen with that 6-hour rule? Well, here's the choice that clinicians have. You can figure out a way for someone to see them somewhere during that, after that interval is passed. Okay? You have therefore met the criterion for diagnosis. But it can be inconvenient for the patient and whoever is going to be seeing them 6 hours apart. The good news, you can follow them meticulously. The bad news, it's inconvenient. Let's take the alternative. It's so inconvenient that you decide this doesn't make any sense, so you send her home and you say, I'll see you tomorrow. Come back to the office. Well, that's going to have you meet, theoretically, the criterion of at least 6 hours. You've met it for now 24 hours. So, on the one hand, that's really very convenient. On the other hand, it does not involve meticulous care of the patient. And the usual compromise is she has to, if she can, come to some unit that's open 24 hours a day. That's usually called a hospital. And someone needs to check her out. Because in truth, if we actually knew with certainty that she would, nothing would go on, then nothing would happen over the next 8, 10, 12, 14, 18 hours, then we're not really, well, no one knows these things. And the only way to care for the patient is for her to be seen. Now, so I would obviously choose number 2. She needs to be requested to come in, or you need to request her to come in and be seen, not the next day when it's convenient for everyone, but when she might have deteriorated. And then there was the distinction between the mild and the severe, and the traditional cut point there was 160 over 110 persistent elevation, and it was now severe gestational hypertension. Well, let's see what happens. For the most part, this condition, the absence of proteinuria, the new onset hypertension, occurred beyond 37 weeks of gestation. And as we'll see possibly on other slides, when it was mild, the outcome was excellent. The bad news was there was a tendency to do something about it, and it led, well, actually not the bad news, the realistic consequence of being beyond 37 weeks is that there was an increased rate of cesarean delivery, mainly due to failed induction. And I'm sure those of us who work on labor and delivery units know that that's the way it was in 2003, and that may still be the way that it is currently. Now, the more severe gestational hypertension, the outcome there and the complications such as abruption, preterm delivery, small for gestational age infants, is very similar to severe preeclampsia. This was not some nothing type mild form of a possible illness. Severe gestational hypertension, the emphasis is on the word severe. These women need to be managed as if they had the proteinuria, as if it was severe preeclampsia. Okay, Dr. Sabai looked at preeclampsia, and as other investigators had seen, and what he wanted to emphasize, there is more to this and its complications than just the disease. The disease itself has significant complications. But what makes it worse are the pre-pregnancy complications or multiple pregnancy. In those days when he was writing, Dr. Savai, assisted reproduction was just in its infancy, and we're mainly talking about twins, but obviously triplets, quadruplets, have an increased incidence of hypertensive complications, other medical conditions, diabetes, renal disease. All of these things made things worse. The good news, mild preeclampsia, as I mentioned, is usually, preeclampsia in Dr. Savai's writing in 2003 now meant the presence of proteinuria. Proteinuria more than 300 milligrams per day on a quantified 24-hour urine. And in those days, mild preeclampsia was more than 300 and less than 5,000 milligrams. Severe preeclampsia in those days was characterized by more than 5,000 milligrams. The good news for the women with mild preeclampsia is that the complication rate for the neonate and complications in general were very similar to normotensive pregnancies. The bad news is that when it became severe preeclampsia, all outcomes that were measured had poorer outcomes. And I made the list here for those who wish to read it. The complications for the mother and the baby with severe preeclampsia were worse than with mild, and for severe preeclampsia that was allowed to linger, the complications were even worse. I've always wondered why there was this separation between preeclampsia and the small number of people who develop a seizure. But that's the way the literature has it. The seizure gives you a new label. However, most of the complications, the horrible complications from maternal death to fetal demise to severe medical complications occur with preeclampsia, not necessarily with eclampsia. Nonetheless, the seizure is hard to miss. Fortunately, it's often self-limited or self-limiting, and it prompts, although cesarean delivery is increased because it prompts induction, it does not, should not, and need not mandate an immediate cesarean delivery. In fact, it's just the opposite. The woman will do better if she is allowed to recover, now medicated possibly with magnesium sulfate if she hadn't been on it before, and have the vaginal delivery. And the fetus will be no worse off if currently fetal monitoring is not in the higher NIH categories. There is a tendency in many institutions to jump to cesarean delivery. But again, it wasn't necessary in 2003, and it's certainly not necessary in 2014 as an immediate response to the end of the seizure. Dr. Savai summarized the antenatal management of severe hypertension. And as Peggy mentioned, for those of you who have now possibly gotten interested in these two publications, this presentation is being recorded, and you can go back and find those references. The people with gestational hypertension and those with mild preeclampsia, these days, given a certain level of confidence that the woman has the capabilities and the facilities to be treated and managed and observed at home, it is safe in some environments. Remember, in 1976, the dictum from Parkland Memorial Hospital was keep them in the hospital. In 2003, there were exceptions to this, but I think the physician and nurse caring for the patient both have to reassure themselves that what they are suggesting is safe, and the home environment or the daycare facility will provide meticulous observation. Blood pressure medications. The use of blood pressure medication for the mild hypertension, which, remember, ranges from 140 over 90 up to 159 up to 109. For the population of people with that range of blood pressures, randomized trials have not shown positive impact on the outcome. I need to stress this, though. If you think about this data that goes from 140 over 90 all the way up to 159 over 109. And again, I have to repeat, for that population of people, antihypertensive medication has not been shown to impact positively. However, the closer you get to that 159 over 109, and the further you are away from 141 over 91, I would like people to consider that there may be some wisdom in starting antihypertensive medication and not wait for that last 1 millimeter of blood pressure to announce itself. A little bit of realism is necessary here. Surveillance, that fetal testing is indicated. That's the good news. The bad news was in 2003, and possibly even now, how frequently what test should be done is as yet not well clarified. There is no doubt that daily fetal kit counts are inexpensive and, in the absence of obesity, reliable and easy for women to accomplish. The other testing, non-stress test, biophysical profile, 2 or 3 times a week was the recommendation in 2003 and still is. Estimation of fetal weight is worthwhile. However, the frequency has to be kept in mind. In the same way, when I go to the gym and I get on the scale and I don't like my weight, so I get off the scale and I get on the scale again, and maybe it's a pound less. And I say, well, that's more like it. It's ridiculous. I do it, but it's ridiculous. In the same way, if a fetus has if an estimated fetal weight is done on Monday, there is absolutely no reason to do it the next Monday. There has been insufficient time for change which can be reliably measured to occur. 3 to 4 weeks may be irksome to the clinician because it seems like it's too long. But that's what the literature shows. I think for someone to sort of act in the middle road here, definitely don't do fetal weights every week. If you have the patience to wait 3 weeks, I mean patience, your own self-ability, not the number of patients, then wait 3 weeks. If you need to do it every other week. And then don't wait for 4 weeks. That's my recommendation. Monitoring, basically in 2003, Dr. Savai was making the same recommendations as 1976. Watch the mother for the detection of severe disease. Nothing has changed since 1976. Looking for organ dysfunction with laboratory testing, signs and symptoms is the key, Dr. Savai and the people from Parkland Memorial Hospital were saying. Laboratory testing, important. It's part of the progression to severe preeclampsia. Protein, serum, this is 2003, serum creatinine, platelet count, liver function test, basically the hallmarks of the HELLP, H-E-L-L-P syndrome. Coagulation tests are not needed in the presence of the traditional normal platelet count and liver function enzymes that are normal. Okay, 10 years pass, and finally we're going to get to the ACOG recommendations. This is a journal article that is easy for modern clinicians to pull up on their computer or go to the hospital library and get. I recommend that everyone read this executive summary. So what did they say? First, not so new, they were dividing the categories of hypertensive diseases into 4 categories. And they were emphasizing the dynamic nature of the disease. And even though that's what's really new in the executive summary, the never-ending warning to all of us that this disease changes. For those who remember what the 1976 journal article said, watch women carefully because things change, and the 2003 statement by Dr. Savai, it really is not new. The emphasis here is do not think that today's, the new wording is pre-eclampsia without severe features. The word mild and severe are now discouraged, mainly so people will get out of the habit of labeling a patient as mild and thinking she's going to stay mild for the entire duration of her pregnancy. So it's called without severe features, implying she could have severe features this afternoon. And the other thing that has been knocked out completely is the dependence upon proteinuria for the diagnosis of preeclampsia. It's hypertension. In addition, the use of the dipstick is, quote, discouraged. You're not told don't ever use it, but you're told there's something better these days. And the severe features, the diagnosis of preeclampsia, can be made on the elements listed here. Platelet count, liver function test, renal insufficiency, pulmonary edema, obviously, and cerebral and visual disturbances. So that's category number 1, preeclampsia. Gestational hypertension is not much different than the previous definition. Chronic hypertension predates pregnancy. Chronic hypertension superimposed is number 1 plus number 4. Prevention. Let's get clear what doesn't work. Vitamins, which may or may not be necessary at all for many women in pregnancy, certainly is not going to prevent preeclampsia. Those with a previous history of early onset preeclampsia, there is still a recommendation for, I guess, for we older men who are using baby aspirin, acetylsalicylic acid at 60 to 80 milligrams is baby aspirin. But here it's potentially, with the emphasis on potential, preeclampsia preventing medication started in the late first trimester. And again, the same emphasis from 1976. Maternal deaths may be prevented if clinicians remain alert that the disease progresses and do not delay diagnosis. When I'm doing teaching of one of the major issues in obstetrics as I see it is that clinicians have a tendency first to deny that there could be anything wrong. There's always some innocuous reason for the woman to have a headache. Maybe her eyeglasses aren't clear, and that's why she's having visual disturbances. Her upper abdominal pain could be just indigestion, etc., etc. Denial of the potential for a serious problem lead to delay in the diagnosis, which leads to death. Denial, delay, death. And once the baby is out, the disease, even though the writing in the classic obstetric textbook was the only cure for preeclampsia is the delivery of the baby. But no one ever said the cure was going to occur with the ACOG of 5 at 5 minutes. The disease is still there. And it was often said that if your blood pressure drops to normal immediately after delivery, you have not cured preeclampsia. You have had postpartum hemorrhage that you just haven't recognized. And that's why your blood pressure makes you temporarily so happy. Nonetheless, the idea that a woman who had preeclampsia goes home with a see in 6 weeks advice is as close to negligence as I can think of. There has to be some other appointment schedule, the frequency of which is dependent upon the severity of the illness in the hospital and how well the mother felt and looked subjectively and objectively when she left. But the one thing that is absolutely wrong is, I'll see you in 6 weeks, have a good time. For women with features suggestive of chronic hypertension, the issue is the clinician comfortable and capable of caring for not well-controlled chronic hypertension? And depending on their capability and comfort level and office scheduling, possibly, actually a strong possibility that having a medical involvement in chronic hypertension may serve the patient's best interest. Preeclampsia management, is that phrase, in the absence of severe features. There is an endpoint to this, and it is at 37 gestational weeks. Not necessarily earlier, but later, which might make your pediatric colleagues happier, is also not recommended. Strict bed rest, it wasn't of any value in 1976, and it's not of any value now. IUGR is not an element of severe preeclampsia. It needs to be treated independently using Doppler measurements. And here comes the area where there is the most controversy now. The ACOG recommendations actively discourage the use of magnesium sulfate when the preeclampsia is without severe features. I believe this is based on the infrequent but real adverse outcomes from overdosing magnesium sulfate. And it was felt that the benefit did not outweigh the risk. No sooner was this recommendation distributed when many knowledgeable authorities in the field disagree. And I know in the hospital I'm at now, this has now been left to the individual judgment of the clinicians. And to review the important message before I shift this over to Peggy, the issue is meticulous vigilance and watching for the progression to severe disease. Peggy, that's it. I'm done.
Thank you, David. Thank you so much for this insightful review of the literature. I think that could be very helpful. Remember, for our audience, you can ask questions by clicking on the orange box up at the right-hand screen with the white arrow, and type in your questions, and we'll answer as many as we can. I think I have just a couple here that I see. First question: can women who are in any of the four categories breastfeed their infants?
I see. The four, you mean the chronic hypertension, the
Right.
chronic hypertension superimposed? Yes. That's the answer is yes.
Good. I know from my own experience, David, that as long as they have support from a qualified lactation consultant and obviously their significant other, one of the things that I did learn about that also is that they need to be counseled that their milk doesn't always come in as quickly as it would under normal circumstances. So that's something to always be aware of. All right, I think I have one or two more.
Well, Peg, can I add on to that, because
Sure.
To be very judgmental about this, I think both you and I are very pro breastfeeding. Okay, so it's coming out in our give and take here. But so
Right.
my thing is aimed at the physicians who might be listening. I think it is quite clear that on the one hand, physicians like to be balanced and say, well, yes, it has its positives, and then take a very well balanced thing. What people who have studied this have clearly shown that when the physician thinks he or she is being well balanced, the patients often hear it as negative. And in this particular case, a little bit of unbalancing will serve the interest of the patient and the physician, in this case, who wants to come over as balanced. Being too well balanced here is not well balanced.
Yeah,
If anyone
I
understood
hear you.
anything that I said.
I hear you. Okay. Although bed rest has not been shown to improve infant outcomes, why is it still being ordered, do you suppose?
Peggy, I just, to be very politically appropriate and not offend anyone, I guess the answer is old habits die hard. And the urge for the physician to be doing something, even if it's close to useless, like bed rest, appeals to many physicians rather than doing less. Doing more seems to be the way our mothers brought us up. Heck, I don't know. Blame it on the mothers. That's all I can say. The physician's mother taught him.
Mother. Okay, we'll do
the
that.
Physician's mother. Don't blame it on the patient. The physician's mother taught him to do more, and I don't know why it persists. It's absolutely. In fact, it causes harm. I think it's quite clear. The issue of thromboembolic disease is higher, but I don't know what kind of side effect. Now I'll get in trouble with all the mothers.
I have another question that just came in. When and what type of antihypertensives should be used?
Okay, well, let's take the when rather than recommending one drug over another, because in truth, the drug usage is a generational thing. So the when, for sure, when the blood pressure becomes severe, 160 over 110. There's no discussion there. And definitely not when the blood pressure is 141 over 91. The issue is when in that middle does benefit outweigh risk? And I think as you're coming close to, and I can't give you the right number, when it's coming close to severe, I would get ahead of the game and not wait for the last millimeter of mercury.
Right.
Now, which drug to use? I have noticed the people in my age, and let's just say I'm old, we still remember Aldomet, which is a good drug. The middle group has nothing to do with Aldomet, and they like Labetalol.
Mm-hmm.
And the youngest group wants nothing to do with Labetalol and uses nifedipine. I don't think there's been a head-to-head competition between these three. And I can only tell you, old people like Aldomet and occasionally will go to Labetalol, and the youngest people have nothing to do with Aldomet, and occasionally they'll use Labetalol, but they really like nifedipine.
So it's probably more a generational thing.
There's no doubt, at least in my observation, it's generational. We get used to what we were trained on.
We have one more question. During magnesium sulfate therapy, is bed rest and Foley catheter use always indicated?
That's a really good question. Not that the others weren't good, but I think what's going on, let's subdivide the question. The issue of Foley catheter is meant to be looking for oliguria. Oliguria as a further complication of a further severe feature in the new preeclampsia with severe features. And I think that it depends on the mother's circumstance. The magnesium sulfate is going to make her less ambulatory, and much time can pass before oliguria of 30 millimeters of urine output per hour may be recognized. And therefore, as a caution to know what's going on for the woman who is less ambulatory and is a little bit more somnolent because of the magnesium, I think it's a good idea. Is it necessary in everyone? No. But on average, I'm seeing it being used more and more. And I think it is for the ease in ruling in or ruling out oliguria. And Peggy, I forgot the first part of the question.
That's okay. Let me get it back. Let's see, during magnesium sulfate therapy, is bed rest and Foley catheter use always indicated?
I think this is now dependent upon the woman's situation. Most people, once they're getting MAG, are in bed. That's different than bed rest. And that's different than if they want to sit in a chair and get their MAG. Can they? Yes. So it's not bed rest as a therapeutic measure, which hasn't been shown to be of any value anyway. It's bed rest because that's how you feel when you're getting a 6-gram loading dose and 2 grams or more an hour of magnesium. This is not the time to be doing marathon training.
We have one more question. What are the risks to the infant when using antihypertensives?
Okay. That's another real... that's a good question. The risk to the infant in general. Now, again, I'm not saying the other questions aren't good also. It's just every once in a while... well, I don't want to say every once in a while. It's a good question. Let's leave it at that. The issue for the fetus is if the antihypertensive medication is pushed too far, like trying to get the patient back to her pre-pregnancy 90/60 blood pressure, or even getting it down to 120/80, you can drop uteroplacental perfusion. So the idea with the antihypertensive medication is you don't have to go back to anything that's absolutely normal. But if you're hovering around 140/90, 130/80, 100 and we'll say 45/95, you're doing fine. She's not going to have the stroke. Remember, the reason for giving the antihypertensive medication is not to get a normal blood pressure. It's to prevent stroke. And strokes are more common when it is above 150/110. So to get away from the 150/110, if you're down there at 140 over something, that's satisfactory. And then the fetus will not have suffer from decreased perfusion.
Good. I also, if you don't mind, David, I'll just add that there is a great book on the market. It's called Medication and Mother's Milk by Tom Hale. And what it does is it lists all of the medications that are out there and the safety of them for during pregnancy and lactation. So that's a wonderful resource. And while we're talking about resources, I should also mention that there are many good resources both for the clinician and the family and the mom. One of them being the Pre-eclampsia organization, www.preeclampsia.org, that provides both support and advocacy for people whose lives have been affected by this condition. So I would just put that out to the group. I want to thank you, Dr. Acker, and thank our group today for the webinar. I wanted just a quick reminder, mark your calendars. The upcoming webinar will be November the 5th, Dr. Richard Waldman, talking about postpartum hemorrhage and are your protocols up to date. The registration information should be coming soon in the next week. You should be getting something. And there would be one more thing just to remind you all that we will be at the Ashram Conference this year in Anaheim, California. We're going to be at booth 111, so if any of you who are out there listening will be attending and want to stop by our booth or even email me, Peggy DeZeno, I'm happy to meet with you or spend some time with you. We look forward to seeing you. So again, thank you all for attending this webinar today. Dr. Acker, always a pleasure. Thank you so much for a great presentation.
You're welcome, Pat.
Please have a good day, everybody. Thank you.
Bye.
Bye-bye.